So previously I alluded to these kind of odd side effects called EPSEs, stands for extrapyramidal side effects. And you've heard of them, at least from Dr. Hall, as part of the movement disorder lecture associated with Parkinson's disease. And so I think definitively you know what they are. We're going to kind of look at them in terms of their ability to be drug-induced. So we'll talk about dystonia, akathisia, and dyskinesias again. And so the treatment option here is to basically restore the balance of dopamine relative to acetylcholine. And in order to do that, we can supply a muscarinic type 1 antagonist, such as benztropine or diphenhydramine. I like this summary chart made by my predecessor, basically discussing the balance hypothesis of striatal function. And so when dopamine and acetylcholine are essentially in equal concentrations, you get normal motor behavior. When dopamine is low relative to acetylcholine, you get hypokinesia. And when dopamine is high relative to acetylcholine, you get hyperkinesia. And that's just quickly summarized on this nice chart. In terms of EPSEs, we'll talk about acute dystonia first, and this is a disorder of involuntary muscle contractions, and it usually manifests itself as the first EPSE to develop, sometimes within minutes to days, in upwards of 90 patients treated with any of these antipsychotics. And this is pretty representative of what some of these patients look like. And so the severity and the incidence of this dystonia really depends on the type of the antipsychotic use. You really tend to see this as prevalent in young males on these high potency first generation typical antipsychotics, and the prime example would be haloperidol. And so typically the remedy is relatively simple. The dose that was just given should be reduced because it was too high. If that can't be done, or if the patient's psychosis demands that the higher dose be administered, you could give an antimuscarinic drug to combat this. And so this is relatively, out of all of the EPSEs, this is probably the easiest one to manage. Akathisia is basically a disorder where the patient can't sit still, and it's common in about 20 to 40% of patients that are treated with schizophrenia, and it occurs more frequently in patients treated with typical first-generation antipsychotics. The timing of akathisia is a little bit delayed relative to dystonia. You can see it manifest itself anywhere from several days to a week after a new therapeutic regimen has started. And the patient presents with agitation and almost seizure-like movements. And of course, it's not a seizure, it's a movement disorder. And it can be managed with anticholinergics. Of course, this has negative effects on cognition. We can reduce the dose of the first generation drug if they're on it. It might even be better to switch to a second generation agent, because as a group, the second generation agents are less likely to produce akathisia. And mirtazapine has been used with some success in the treatment of akathisia. And so we can kind of transition into more chronic EPSEs, and you can talk about tardive, or essentially tardy dystonia. And so it's really similar to acute dystonia, but it occurs later in the course of therapy. So this would be a patient who becomes dystonic after, say, several months of therapy. In contrast, tardive dyskinesia would be kind of an odd hyperkinetic choreiform type movement. And kind of the best example would be Miley Cyrus, because you can see the tongue is out. Some of these patients exhibit a lip smacking behavior. And in fact, that's how some older psychiatrists would know that some of these patients are actually taking their medication, because they would make this lip smacking sound similar to this. And you can see kind of these odd choreiform dance-like movements. Tardive dyskinesia can be subdivided into breakthrough and withdrawal, and we'll elaborate on that in the next slide. So dyskinesias, if it's a withdrawal dyskinesia, it's a tardive dyskinesia. It's chronic, it's more common, and it typically occurs when the antipsychotic agent is abruptly removed or discontinued, often sometimes by the patient. And then again, this is really kind of explained by these counter-adaptation mechanisms, where you can see an upregulation of dopamine receptors relative to the potential ligand dopamine available. In contrast, breakthrough dyskinesia tends to be acute, but it's also more serious. This is where, in spite of being on a D2 antagonist, these movements actually break through the blockade. What's interesting and what's the most important thing to remember is that these type of breakthrough dyskinesias occur when the patient is on the drug, and they can be permanent. Okay, here the counter-adaptation mechanisms are very extreme, and it's really hard to treat breakthrough dyskinesias. And so from a mechanistic standpoint, we can see lots of dopamine receptors and lots of dopamine antagonists being on board, and it really can be problematic because it's almost impossible, not impossible, but almost impossible to treat. So I really like this slide. This really kind of sums up the pharmacodynamic interactions that we can see with alterations in dopamine receptor. And so, excuse me, I keep having to stop the recording because I'm sick. So anyway, this is a nice kind of summary chart. And so what we see here is kind of normal physiology, and you can see there's essentially 3 dopamine molecules per 6 dopamine receptors, and we get normal movement. Okay, here's an example of a withdrawal tardive dyskinesia. So this would be an abrupt kind of withdrawal of a medication, and here you can see counter-adaptation already has occurred. And so what used to be 6 receptors has been increased to 9 receptors, and then now there's more dopamine available to bind to these receptors, and so you can get some of these breakthrough, some of these choreiform type movements. In breakthrough TED, the only difference here is that now the drug has been continued. You get basically an increase in receptor number. Now we're up to 10 receptors, and we're co-administering a dopamine antagonist as the square box, and then the endogenous dopamine as the circle. But because there's more receptors relative to what was here before, you can see that now dopamine, any dopamine, endogenous or otherwise, has a more profound effect. And that's really just due to the fact that there's more receptors available for dopamine signaling. Okay, and so in terms of the treatment, we can best to avoid or prevent the development. And so we can slowly talk about increasing the dose as needed, but we really try to avoid producing tardive dyskinesias altogether. There's been marginal success with tetrabenazine. It's really kind of the first choice. Officially, it's a VMAT/norepinephrine dopamine depleter, and it can produce a hypotensive crisis when given in high doses, of course. It's been off-labelly used for tardive dyskinesias. It's part of the Huntington's disease literature. There's really no clinical data that says this works better than anything else, but it is costly. Razapine has a similar mechanism of action. It's a dopamine storage depleter VMAT inhibitor. Razapine is kind of overkill because it's so potent. Benzodiazepines may work, and ironically, vitamin E can work as well. But again, the clinical data has not been robust, so to speak, and we're not really sure what the mechanism is behind that. Anyway, Other clinically significant drugs for psychoses include antimuscarinic agents such as benztropine. This drug is anticholinergic and antihistaminergic. It can be given a variety of ways, both intramuscularly, IV, orally, and it is indicated for EPSEs. Also, along those same lines, we can use trihexyphenidyl, an antimuscarinic drug as well. So this concludes the relatively odd side effects of EPSEs and some of the management approaches to them. None of these approaches are wonderfully efficacious, but they can work. It's just relatively easier to approach these side effects with caution so that they don't manifest themselves.